Well, good morning, everybody. It's a pleasure to see you all again today. We have a special Grand Rounds lecture this morning. We have Dr. Paula Amato. She's an associate professor of obstetrics and gynecology at OHSU. She completed her medical degree and residency in obstetrics and gynecology at the University of Toronto, and then completed a fellowship in reproductive endocrinology and infertility at the University of California in San Diego. She joined the OHSU faculty in 2007, and she's here today to talk to us about menopause and hormone therapy.
Thank you, Jesse, for the introduction, and good morning, everyone. Thanks for the invitation. I'm glad to be here today. I think there kind of needs to be more dialogue between the OBGYNs and the internists and other primary care providers, because I think ever since WHI, the Women's Health Initiative study, my impression has been that we've all retreated to our respective corners, and maybe there's more of a divide. At least that's my perception. So what I hope to do today is share my perspective. I have no financial disclosures on the evaluation and treatment specifically of the perimenopausal woman, and then just bring you up to date on the latest evidence regarding the risks and benefits of hormone therapy. So I have a lot of slides. I'm going to go through them fairly quickly, and hopefully there'll be time at the end for some questions. So I think you're all familiar with the concept of menopause. Women are born with a finite number of eggs. They don't make any more eggs after they're born, unlike men who produce sperm until they die. Eventually, women run out of eggs. So the traditional definition of menopause is a year since the last menstrual period, and that's kind of a retrospective diagnosis. In reality, usually don't wait until menopause to treat someone. Women tend to be most symptomatic in the perimenopause period, where their periods may be irregular, and certainly it's totally appropriate to treat someone in the perimenopause. You don't have to wait till menopause. The average age of menopause in the United States is 51. If it happens earlier than, say, age 40, we tend to call that premature menopause. Normally it's spontaneous, but of course it can also occur following surgical removal of both ovaries, or if the patient undergoes gonatotoxic therapy with either chemotherapy or radiation. We're all going to be seeing more women in the perimenopause and the menopause. It's estimated that about 2 million women a year enter menopause in the United States, and that's because life expectancy, of course, is increasing. So the average age of menopause, as I said, was 51. Women are now living into their early 80s, so that means that most of us are going to be living about a third of our lives in menopause. That's very different than up to even just 100 years ago, when the life expectancy was 50, women kind of died at the end when they reached menopause. But now they're living about a third of their lives in the postmenopause period. The classic symptoms are familiar, I think, to all of you. Most women will experience some change in their menstrual cycle. Hot flushes are particularly common. Vaginal dryness is also common. Other symptoms, things like psychological symptoms, cognitive symptoms, are a little bit less specific, but many women also complain of these things at the time of perimenopause and postmenopause. I want to introduce you here just to the STRA criteria, which is mostly of academic interest, really, but it's an attempt for researchers to kind of standardize some definitions, and it kind of divides woman's lifespan into the reproductive years, post-reproductive years, and the menopausal transition. And this menopausal transition is variable in length. It could last usually up to 4 years or so. And then down here, you can see what happens biochemically. The FSH tends to increase. The AMH, I don't know how many of you are familiar with that particular hormone, anti-Müllerian hormone. It's a hormone we use a lot in the fertility world, but people are now using it for menopause as well. And it's made by the granulosa cells in the ovaries. So as you run out of eggs, your AMH level decreases. So the AMH and the FSH are inversely proportional to each other. Same with estrogen, of course. Estrogen decreases in menopause. Just a reminder of the hypothalamic pituitary ovarian access. The hypothalamus secretes GnRH, which then stimulates the pituitary to secrete the gonadotropins, which stimulate the ovary then to produce the sex steroids, estrogen and progesterone. And there's a negative feedback loop. So you can see as ovaries run out of eggs, estrogen levels decrease, FSH level increases. Having said that, you rarely have to measure hormones to make a diagnosis of perimenopause or menopause. It's mostly a clinical diagnosis, but this is what's happening biochemically. So AMH, I mentioned, is still not totally mainstream in the menopause world. There was, in the last year or so, an assay approved to diagnose menopause based on AMH level. Basically, it needs to be undetectable. But perhaps in future, we can use the AMH level to maybe predict how soon someone might go through menopause. Again, this is what's happening biochemically. Estradiol levels are decreasing and FSH levels are increasing. In the perimenopause specifically, it's really not useful to measure levels. They can be very erratic. Sometimes you can get super high levels of estrogen. If anybody's ever checked an estradiol level in perimenopause, you might be surprised to find it in the hundreds. And that's because the FSH is high, and if the estrogen, if there's some granulosa cells that are responding to the high FSH, they're going to produce a lot of estradiol. So again, not super helpful in terms of diagnosis or management. These are some of the other biochemical changes that happen. There tends to be a decrease in the estrogen-androgen ratio. So some women in postmenopause, they'll start complaining of chin hairs and things like that. And that's not so much that the androgens are increasing, but just that the ratio of estrogen to androgens is changing somewhat. You're still getting some androgen production, and those androgens are getting aromatized in the fat cells to estrogens. The main estrogen in postmenopause is estrone, or E1, as opposed to premenopausally estradiol is the main estrogen. Testosterone levels decrease with age, but don't significantly change with menopause. They decrease over time as women get older, but it's not like there's a dramatic decline at the time of menopause. Unless somebody has their ovaries out, then it's a little bit more abrupt. Okay. Weight gain, many women gain weight as they get older. There's no evidence that menopause per se increases weight gain or that hormone therapy increases weight gain. There's a little bit of evidence that hormones might affect fat distribution. But the fact that hormones cause weight gain, similar to the birth control pill, is not really borne out in studies. I mentioned one of the most common symptoms is some change in the menstrual pattern. Typically what happens is the cycles get shorter. Occasionally women might miss a period. Eventually the menses cease altogether. I do have a very low threshold to evaluate abnormal bleeding. And my definition of abnormal bleeding, any heavier bleeding than usual, bleeding after intercourse, intermenstrual bleeding, those are all things that are a little bit more concerning and do warrant some evaluation. It could be that it's just perimenopause, but you're kind of sort of obligated to work that up. Also, if someone has gone through menopause, hasn't had bleeding in several months to a year, and then they have bleeding again, of course, that needs to be evaluated. The evaluation is going to depend a little bit on the presentation, certainly history and physical. Depending on how heavy the bleeding is, you might get a CBC. It's worthwhile to get a TSH because some thyroid abnormalities can cause irregular bleeding. Sometimes you need to do an endometrial biopsy to rule out endometrial pathology. Imaging is often helpful to look for structural abnormalities like fibroids or polyps. And occasionally, depending on what you find in these preliminary tests, you might need to do a DNC or sonohistogram or hysteroscopy. You might have heard about endometrial thickness and measuring that to guide your diagnosis. It's not particularly helpful in premenopausal women. Okay, so it varies with the menstrual cycle, so it's not helpful actually at all in premenopausal women, unless it's super, super thick, and that might, clue you into something like hyperplasia. especially in someone who has something like PCO, perhaps. But in the postmenopausal women, if the thickness is less than 4 millimeters, that's reassuring. It's very unlikely that there is a malignancy there. So if somebody comes in, postmenopausal bleeding, you do an ultrasound, the thickness is 3 millimeters, you don't necessarily have to biopsy that patient. Of course, if it persists and is bothersome, then you might want to evaluate for a polyp or do some further evaluation. Vasomotor symptoms or hot flashes, super common. Notice there's a typo there. Symptoms. Yeah, okay, sorry about that. The majority of women will experience hot flashes, but they're not usually debilitating in most women, although in a small percentage of women they are. They tend to be most severe in the perimenopause, as I said. They can last, usually on average, about 4 years or so, but in some women they can actually last much longer than that. And they tend to be more severe in smokers for some reason. We don't really know what causes the hot flashes. We think there's some sort of change in the thermoregulatory temperature set point at the level of the hypothalamus. Luckily, there's lots of good treatments. For hot flushes, hormones work great, and for women who can't take hormones or would rather not take hormones, there are some other alternatives which I'll mention a little bit later on. They're not quite as effective as estrogen therapy, but they're moderately effective. Sleep disturbances, also super common at midlife, particularly more common in women for some reason. We now know a whole lot more about the importance of sleep and the association between sleep disturbance and other conditions such as depression, cardiovascular disease, obesity, etc. There's lots of different causes. You probably know this better than I do, but lots of different causes of sleep disturbances, so it's important to kind of figure out what is causing that and not necessarily just attribute it to hot flashes, which tend to be more frequent at night, and that can cause sleep disturbance as well. And whether or not you treat it depends on, and how you treat it depends on what the underlying cause is and how bothersome it is for the patient. Sleep hygiene, super important. I know you know this, so I'm not going to spend much time on it, but very important. Hormone therapy is not FDA approved for sleep disturbances per se, but it actually works pretty well. So certainly, if the sleep disturbance is due to hot flushes, it relieves hot flushes, so that helps with sleep. But even independent of that effect on hot flushes, there's some data to suggest that hormone therapy, particularly micronized progesterone at bedtime, improves sleep quality. And that's actually one of the most common symptoms that women have in the perimenopause, just like really disrupted sleep. Cognitive changes are super common as well. There is some evidence that verbal memory decreases at the time of perimenopause. Luckily, it seems to be mostly transient. It's important to distinguish between, what's menopause, what's normal aging, what's dementia, and I know you guys know about diagnosing dementia, again, better than I do, so I'm not going to go into that. This is a small study. This is actually in premenopausal women, and what they did is they gave these women a GnRH analog, so put them, like Lupron you've heard of, put them in medical menopause, and they showed that there's definitely some decrease in the verbal memory. And when they then randomized the group to receive estrogen therapy versus placebo, they saw improvements in that verbal memory in the estrogen therapy group. So that suggests that hormones actually do play a role in memory. Mood disorders, also common at midlife, again, very multifactorial. Some of the risk factors for depression at midlife include a history of premenstrual syndrome, significant stress, sexual dysfunction, physical inactivity, and again, hot flushes if you're not sleeping, fatigue, etc. The biggest predictor of depression at midlife is a history of depression prior. Makes sense. And different things are helpful. Hormone therapy is not typically effective to treat clinical depression. It may be helpful to treat kind of depressed mood that's associated with perimenopause due to fatigue and lack of sleep and hot flushes. But if someone meets criteria for clinical depression, typically they'll need either psychotherapy and or antidepressant medication. Stress reduction techniques, of course, help as well. Vaginal dryness experienced by the vast majority of women, and unlike hot flushes, they don't tend to go away. They tend to like persist or get worse over time. Again, luckily, there's good treatments for that. Local estrogen, systemic estrogen, both work very well. We also recommend lubricants and moisturizers and regular sexual activity. If someone doesn't want to take systemic estrogen because they're concerned about side effects or whatever, there are a couple of local vaginal preparations on the market that aren't absorbed systemically that are very effective for vaginal dryness. But of course, you don't get the systemic benefits. Either would not prevent osteoporosis or anything like that. And those two, just to kind of have it at the back of your mind, one is called Vagifem, and it's actually a little tablet you put in the vagina. And the other one is Estring, which is a vaginal ring. You can put in the vagina, leave it in for 3 months, and change it out. And those are, it's just estrogen. You don't need to give a progestogen even if the patient has a uterus because it's not absorbed systemically. It's not getting to the endometrium. You're not going to get protection of bone or anything like that or treatment of hot flushes, but it's very effective for treating vaginal symptoms. Urinary complaints are common as well, specifically incontinence. There's lots of different kinds of incontinence, of course. You have to kind of figure out which type of incontinence patient has, and that usually you can figure out on history. Occasionally you'll need to do systometric testing to distinguish between the different kinds because it's important to do that because the treatment obviously varies. So for stress urinary incontinence, typically we treat with either pessaries or surgery, whereas urgency incontinence or overactive bladder, we tend to treat with medications. We used to think that systemic estrogen therapy or hormone therapy actually improves stress urinary incontinence, but WHI and other studies have shown that actually that's not the case. If anything, it makes it worse. So if somebody has stress urinary incontinence, you don't want to treat them with systemic hormone therapy, or for that reason anyway, to expect that would get better. On the other hand, if somebody has urgency incontinence or overactive bladder, sometimes that's associated with like vaginal dryness that could trigger that. Local estrogen in that scenario tends to help a little bit. So kind of important to figure out what your patient has. Sexual complaints are common in this age group as well. Certainly if somebody has vaginal dryness and that's causing pain with intercourse, that can cause sexual dysfunction. Decreased libido is also a common complaint in this age group, and we don't think estrogen and progesterone play much of a role. There's some evidence that testosterone might play a role in libido. So for the vaginal complaints, giving estrogen can often be helpful, but for the decreased libido complaints, that might not, it won't necessarily help. Unfortunately, there's no FDA-approved testosterone formulation available for women on the market in the United States. There is a testosterone patch available for women, available in Europe, but we don't have it here. And you know, obviously libido is very complex and multifactorial, so it's really hard to determine that it's, you know, due to decreased testosterone. It's almost a diagnosis of exclusion when you've ruled out a whole bunch of other things like depression, interpersonal problems, etc. But very occasionally I will treat this in my postmenopausal women with testosterone, and I have, because there's no FDA-approved formulation on the market, I use compounded testosterone, which has a whole set of issues because it's not regulated in the same way, so you don't really know what you're getting, and but it's the only option you have. The products on the market for men tend to be much higher doses than you would use in women, so I tend not to use that. So the biggest thing I worry about with the compounded testosterone is that the woman's going to get too much. So I do monitor levels in those patients just to make sure they're not getting supraphysiologic levels, which of course is associated with a whole bunch of side effects. And I use it very rarely. Probably the most common situation that I use it in is a woman who's had surgical menopause, both her ovaries removed. I've ruled out all other causes of decreased libido. In that patient, I've seen some response because the postmenopausal ovary actually continues to produce small amounts of androgen. So in surgically postmenopausal women, their androgen levels tend to be much, much lower than even spontaneously menopausal women. And of course, there's other drugs on the market now for decreased libido. You might be familiar with flibanserin, which is a centrally acting medication, works on serotonin receptors, and has been used also for decreased libido. Wellbutrin is another medication. All right, so I'm going to, this section, talk a little bit about kind of health maintenance in this group, and you guys are all internists, primary care people, and you know this stuff better than I do, so again, I'm not going to spend too much time on this section, but we all know cardiovascular disease obviously is the biggest killer of women every year in the United States, and the incidence seems to be increasing, especially in younger women, because of the increased incidence of diabetes. It's important to optimize, obviously, blood pressure, blood sugar, cholesterol, lipid levels, etc. Modify lifestyle factors to try and prevent heart disease, maintain weight, etc. Statins, of course, as you know, have been shown to be effective in preventing heart disease in women who have hypercholesterolemia. My understanding of the aspirin story, and you can correct me if I'm wrong, but low-dose aspirin in older women is effective for preventing heart disease, and in younger women at risk for stroke, particularly high risk for stroke, there's some evidence that it may be protective there as well. Osteoporosis, of course, is another leading cause of morbidity in this age group. Tends to be more common in women. Men lose bone as well, but because they start off at a much higher peak bone mass, they don't tend to develop osteoporosis as often. So of all the 10 million Americans in the United States with osteoporosis, 80% of them are women. And we know that estrogen is super important for bone health. And you lose quite a bit of bone as soon as you go through menopause. Okay, how do we diagnose osteoporosis or low bone mass? Obviously, DEXA scan is what we consider the gold standard. A T-score minus 2.5 is considered osteoporosis. Quite clear that you should treat those patients. The middle group here, the osteopenia or low bone mass group, is the one where I feel like it's kind of shifted in the last few years. We used to treat all these people with either estrogen or bisphosphonates or something. Now there's more, people are being a little more selective in who to treat based on their risk because of some of the side effects of some of the treatment modalities. Also important to remember the ethnic difference when it comes to osteoporosis. So white and Asian women tend to be at higher risk than Black and Latina women. So we use the FRAC score quite a bit. I don't know if you guys do, but we use that to help determine whether or not to treat people in the low bone mass group. Okay, there's lots of different treatments. These are some of the risk factors that go into the FRAC score. Obviously, age, sex, weight, height, history of prior fracture, a family history of a fracture, osteoporosis, and a T-score if you have it. I always see women who come in this age group and they say, I don't understand, I'm super healthy, I exercise all the time, I do my weight-bearing exercise, and how could I have low bone mass? And it turns out, probably they have bench genes. Maybe 50 to 80% of our bone mineral density is determined by genetic factors, and nutrition, exercise, the rest. I tend to have a low threshold for doing a DEXA scan. It's recommended in anybody over 65, but I will often do it in a younger woman, especially if they're trying to decide whether or not to go on hormone therapy. I find that their baseline bone density actually can be a useful another parameter they can use to make that decision. Obviously, If the FRAX score indicates an elevated risk, or if somebody's had a prior fracture, then you should get a DEXA scan in that patient. These are some of the other risk factors: smoking, rheumatoid arthritis, chronic steroid use, excess alcohol, etc. The DEXA scan gives you a T-score at the hip, the femoral neck, and the AP spine, and you typically will use the lowest T-score to make your diagnosis. Important to rule out secondary causes and just not assume that it's just menopause or perimenopause, and those would include things like hyperthyroidism, certain medications, vitamin deficiencies, chronic steroid use, as I said, rheumatoid arthritis, celiac disease, etc. These are important adjuvants. Obviously important to supplement calcium and vitamin D, especially in Pacific Northwest. I find everybody's low on vitamin D. We tend to measure it. I've heard from a lot of internists, they just kind of treat everybody empirically. Probably not a bad idea. I think measuring it, the only way it helps us is sometimes we'll use the high dose replacement in someone who's really, really low. Exercise, diet, fall prevention, also super important. So in your, it's pretty clear you treat the patients with osteoporosis, and in the low bone mass group, only if the FRAX score indicates a higher risk of an osteoporotic fracture in the next few years. There's lots of different options in terms of osteoporosis prevention, in terms of treatment. There are no head-to-head trials to say that one particular treatment is better than another. These are some of the ones that are available, including estrogen, which is approved for osteoporosis prevention, but not for treatment. And I would say of this group, probably the ones I use most commonly is the bisphosphonates. It has its own set of side effects that you have to counsel the patient about, but there's some other options available. Some of them are newer, like I don't have much experience, for example, with this rank ligand inhibitor. Prolia is the brand name. Most of them work on bone resorption and decreased bone resorption, except for the parathyroid hormone, which is anabolic and actually increases bone formation. Diabetes, also common, increasing prevalence and incidence because of the obesity issue. Hormone therapy, not FDA approved to treat diabetes. These are all the risk factors for diabetes. You guys know this already. Polycystic ovary syndrome, important gynecologic condition that increases your risk of metabolic syndrome and diabetes. So it's important to identify that risk factor in the history. I guess fasting blood glucose is considered the gold standard. I tend to use hemoglobin A1C just because it's more convenient. The patient doesn't have to be fasting. Important lifestyle modification and other things to control diabetes. As far as hormone goes, it's not approved for the treatment of diabetes, but there is some evidence that hormone therapy actually decreases the prevalence of diabetes incidence. Don't exactly understand how it works yet, but that seems to be consistent in some of the studies. As far as cancer risk, it does not necessarily increase with menopause per se, but most cancers increase with aging, so you tend to see more of these cancers in the perimenopause, postmenopause age group. You all know that breast cancer is the most common cancer in women. Lung cancer is responsible for the most deaths, followed by breast cancer and then colorectal cancer. Of the gynecologic cancers, endometrium is the most common, but ovarian cancer causes the most deaths, just because it's usually diagnosed late, and there are no effective treatments for late-stage ovarian cancer typically. As far as screening, this keeps changing, as I'm sure you're aware. So kind of the latest screening guidelines as far as mammogram goes, everybody agrees in the 50s to age 74, 75, every couple years. There's less agreement about what to do with women in the 40 to 50 range. The I still offer screening to my patients, at least a baseline at 40 and every 2 years if they want to have screening in that age group. Some data to suggest that there's a higher incidence of false positives in that age group, and you may be subjecting women to unnecessary biopsies and that type of thing. So that's where the controversy is. Of course, if they've had, family history of early breast cancer or whatever, then the screening guidelines obviously are going to change. As far as colorectal screening, used to be a colonoscopy starting at 50. The most recent guidelines, of course, are 45. And for African Americans, it's always been 45. I don't know if that's since decreased to 40 after the screening recommendations in Caucasians decreased to 45. Unfortunately for ovarian cancer, there's no effective screening tool. We still recommend pelvic exams every year, but to be honest, there's like zero evidence that that's an effective screening method. If somebody has like a BRCA mutation or something, then obviously it's recommended for them to have, every 6-month pelvic ultrasounds and CA-125s and that type of thing. But for your average woman, we're still just recommending annual pelvic exam. So even if you're not doing the pap smear every year, you should still be doing the pelvic exam. And pap smears, by the way, will go away soon, and you'll just be doing HPV tests maybe every 10 years. So it's really hard to know what to do with ovarian cancer. Reality is pelvic exams aren't very good, and we don't have an effective screening method. Mentioning pap smears, so the current guidelines are every 3 years or every 5 years if you do co-testing with HPV. And you can stop doing them at age 65, okay, unless they have had a history of cervical cancer or dysplasia or something like that. But most of us think that this is, this interval is going to increase even more in the coming years. Okay, moving on to hormone therapy. So usually when we talk about hormone therapy, we're talking about estrogen and progestogens, some formulation of those. Anybody who has a uterus who you give estrogen to, you have to give a progestogen to prevent endometrial hyperplasia. If the patient does not have a uterus, there's no role for progesterone. You can give estrogen only. This other term that you might hear occasionally is bioidentical hormones. It means different things to different people. I use it to mean the hormones that the ovaries were making prior to menopause, and that's 17-beta-estradiol and progesterone. Okay? That's what I tend to prefer when I give somebody hormone replacement. Not that I know that that's any better than any other formulation out there, but just intuitively that makes more sense to me. WHI, by the way, was done with conjugated equine estrogens and synthetic progestin, medroxyprogesterone acetate. So in the absence of data for these other formulations, we have to assume that the WHI results apply to all the different formulations, but nobody has really, and no one ever will, repeat the study with other formulations. Okay? Other people, especially lay people, use the term bioidentical hormone to mean compounded hormones. Okay? They're not recommended in general by North American Menopause Society and other sort of professional organizations, only because they're not regulated in the same way. So we don't have the same data in terms of efficacy and safety, which is not to say that they aren't safe or effective, but they haven't been proven to be. So when you have an alternative, FDA-approved alternative that has been proven, and I can tell you exactly what the risk-benefit profile is, that tends to be my preference. Having said that, we're in the Pacific Northwest. Lots of patients prefer compounded formulations. They'll come to me already on them, and I don't send them away. Of course, I keep them in my practice. If they're going to use compounded hormones, then I would rather they use them under my supervision so I can monitor them for efficacy and for side effects. So I have plenty of people on compounded hormones. And I use them myself when I use testosterone, which is rare, but occasionally because I don't have an alternative. But if somebody asks for my opinion, then obviously I'm going to recommend an FDA-approved formulation. There's a multitude out there. You just should become familiar with a couple that come in different dosages, different routes of administration. There's some data recently to suggest that maybe transdermal routes of administration might be a little safer than oral because it avoids the first pass effects. So maybe there's a decreased incidence in clotting, thromboembolic disease, et cetera. That's mostly speculative. It's not based on good outcome data, but seems to make sense. So I usually leave it up to patient preference. There's some patients who prefer patches, some who prefer pill. I don't have a strong preference for either. There's also the IUD for somebody who is concerned about the progestin. Unfortunately, there's not a progesterone IUD. All the progestin IUDs on the market are synthetic progestins, levonorgestrel usually. Okay, and remember that all the products are on the market are approved, most of them for hot flushes, vaginal dryness, and prevention of osteoporosis. The only FDA-approved indications for hormone therapy. All the other stuff I talked about is not FDA-approved. Okay. As I mentioned earlier, if somebody just has vaginal symptoms and they don't want to take systemic hormones or they're concerned about the side effects, then there's Vagifem, Estring. There's also a newer product on the market that's vaginal DHEA. It's called Intrarosa, and those are effective for vaginal symptoms. You don't get the systemic benefits, but you don't have to worry about the systemic side effects either. WHI, of course, over 15 years ago now, threw a big loop into all this. We used to recommend it for hormone therapy for most women. WHI obviously showed that there was no benefit in terms of prevention of cardiovascular disease, which actually was the main reason they did this study. Since then, there's been sort of a lot of controversy, I would say, because this was the first large prospective randomized controlled trial, and the results were very different than all the epidemiologic data we had prior to this that seemed to suggest that women who took hormones actually did better in terms of cardiovascular disease, et cetera. Problem with that epidemiologic data or observational data is that it could be biased. Maybe women who are taking hormones are healthier in other ways. Maybe they exercise more. So that's why that data is not considered a gold standard, and this is. Having said that, there are some issues with WHI as well. Because they excluded women who had severe hot flushes, they ended up with women who were a little bit older than what you would typically see. So the average age in WHI was 63. I have very few 63-year-olds who come to my office asking for hormones, okay? Typically, late 40s, early 50s at the onset of perimenopause is when women will come see you for some type of treatment for their perimenopausal symptoms. So what we know for sure from WHI is that giving hormones to women who are older, who have been post-menopause for at least 10 years, not a good idea. You're going to actually increase their risk of heart disease. What's not clear is what if you start it early? What if you started right at the time of perimenopause? Could it still be protective? And that's kind of one of the theories, the window hypothesis. That's kind of people are trying to use that theory to reconcile the difference between the observational data and the randomized control trial data. My personal opinion is that there might be something to that. When they reanalyzed the WHI data, it did in fact show that the people in the trial who started it earlier, the hormone therapy, actually seemed to have a lower incidence of things like heart disease, et cetera. So, it's not proven, not FDA approved, but that's my personal opinion. What we know for sure, should not start it if somebody already has cardiovascular disease, or if they're older, or if they've been post-menopause for more than 10 years. Okay. I mentioned this already in the WHI. It was done with a particular formulation. Whether or not that other formulations are safer, nobody really knows. For the time being, you have to assume that all the medications in this class probably have the same kind of risk-benefit profile. Hormone therapy works great for vasomotor symptoms. Lots of different options there. Works great for vaginal symptoms, and I'll talk a little bit about non-hormonal options in a second. Sexual function, if the sexual dysfunction is due to dyspareunia, that's due to vaginal dryness, hormone therapy, works great. For libido, not so much. Maybe some role for testosterone, as I mentioned. Urinary tract health I mentioned as well. Systemic hormone therapy is not effective for stress urinary incontinence. Okay? Local estrogen therapy may be effective for urgency incontinence or overactive bladder. Yeah. Okay. Osteoporosis, again, not approved for treatment of osteoporosis, but approved for prevention. However, there are lots of non-hormonal options for prevention of osteoporosis as well. And how long should you keep somebody on hormones if they're taking it specifically to prevent osteoporosis? There's kind of like no stopping time, really. You'll only get the benefit for as long as you're on it. As soon as you stop it, you'll start losing bone. So if this is the main indication for taking the hormones, then I will keep my patient on hormones sometimes for decades, as long as they don't develop some sort of absolute contraindication. Heart disease, as I mentioned, not recommended for prevention of heart disease. This question about whether it may be preventive if you start it early is still out there, but obviously that's completely off-label and not proven. Stroke, there does tend to be a small increase in thromboembolic disease and stroke in women taking both estrogen only and estrogen progestin combination. The absolute risk, however, is quite small, right? So if the stroke risk, let's say, is 1 in a million, even if you double that risk, it's only 2 in a million. So it's still low. And remember, these are replacement levels, okay? They're not like, birth control pills tend to be even much higher levels of estrogen than what we would typically give postmenopausal women. This is meant just to replace same levels that the ovaries were making prior to menopause. Thromboembolic risk is a similar story. Definitely an increased absolute risk, but that absolute risk is small, and maybe transdermal may be safer than oral. So certainly if you have somebody who wants to take estrogen but is worried about the clotting risk, maybe they have a family history or something of a clotting disorder, then you would probably choose a transdermal formulation. I don't typically screen my patients for thrombophilias unless they have a history of a DVT, or if they have a close relative that's known to have a thrombophilia, then I might screen them. But in general, I think you can get false reassurance by just screening. I mean, there's probably a gazillion thrombophilias that we're not familiar with. They're not known, so you can't really test for. I do think that people that probably develop clots on estrogen probably do have some genetic predisposition, and we're just limited in the ones that have been identified thus far and can test for. Diabetes, as I mentioned, not FDA approved for this indication, but there seems to be some data to suggest that it decreases the incidence of diabetes. Not exactly sure what the mechanism is yet. Endometrial cancer, this has been known for a long time. If you give unopposed estrogen, bad for the endometrium, right? It increases the risk of hyperplasia, and cancer should never do that. Anybody who has a uterus who's taking systemic estrogen, you have to give a systemic progesterone. Breast cancer, there's probably also an increased risk in breast cancer with, at least with the combination estrogen progesterone therapy. In WHI, the women who got estrogen only did not have an increased risk in breast cancer, which is kind of weird, but that's what the data showed. It's not entirely clear that hormones cause breast cancer, but certainly if you have a breast cancer there, it's going to increase it, or it's going to make it grow. So certainly if somebody has a personal history of breast cancer, it's a contraindication to hormone therapy. Very rarely I'll have somebody who wants to take estrogen despite a history of breast cancer, or if they're BRCA positive and at high risk for breast cancer, and then it becomes a quality of life issue. You can try non-hormonal alternatives, but if those don't work, then there might be a role for hormones. And it seems to be with breast cancer that the longer you're on it, probably the higher the risk. Again, the relative risk is increased, but the absolute risk is still quite low. So, you know, you have to consider what the woman's baseline risk for breast cancer is. If her baseline risk is average, even if you increase that relative risk by 40%, it's still going to be quite low. On the other hand, if you have a patient whose, you know, mother, grandmother, aunt all died of breast cancer, and she's got, you know, a BRCA mutation, her baseline risk is all of a sudden, you know, 80%. If you increase her relative risk by 40%, it's a much bigger deal. So kind of keep that in mind. Yeah, okay. I'm just going to go through in the interest of time a little faster here. Again, longer durations seem to increase the risk, not in the estrogen-only group. So actually, this is reassuring in somebody who's had a hysterectomy who doesn't need a progestogen, and they're considering whether or not to go on hormone therapy. You can reassure them that, at least from WHI, estrogen-only therapy did not increase the risk of breast cancer. So, ovarian cancer, it's not common enough that the numbers were too small in WHI anyway to make any definitive conclusions. There seemed to be more cases in the hormone therapy group, but it did not reach statistical significance, and probably that's just because the numbers were too small. Ovarian cancer typically is not considered an estrogen-dependent cancer, so maybe perhaps that's not that surprising. As far as mood and depression goes, again, not indicated for clinical depression or depression that meets clinical criteria, but can be helpful in, you know, dysthymic mood, depressed mood that's associated with perimenopause, fatigue, hot flashes, etc. For true clinical depression, then, you know, antidepressants and psychotherapy and/or psychotherapy is more effective. Interestingly, some antidepressants can be helpful for hot flushes. So if you have somebody who has hot flushes and depressed mood, sometimes I'll, you know, start them on an antidepressant, especially if they don't want to start on hormones. And you can see sometimes improvement in both their mood symptoms and their hot flushes. Aging, dementia, cognitive aging, dementia, another sort of controversial area, very similar to the heart disease area. So we used to think that hormone therapy was preventive against Alzheimer's and other forms of dementia. WHI showed the exact opposite. So people in the hormone therapy group actually had a higher incidence of dementia and cognitive impairment. And again, it's not clear, is it because they started hormones late and maybe whatever sort of pathophysiology causes this was already established, and giving hormones at that point is not helpful and could be harmful. Not clear whether giving it early, time of perimenopause, women in their 50s, whether it could still be preventive. Okay, there's trials ongoing, but reality is there's never going to be another trial the size and scale of WHI. So we may never know the answer to this. Premature menopause or premature ovarian insufficiency is the new term. That's when menopause happens before age 40, typically. We tend to think that for these women, they're kind of a different category, that for them, probably the benefits of hormone therapy outweigh the risks, at least until the average age of menopause, which is around 50, 51. Because if they go without estrogen from like in their 30s or 20s sometimes, they're almost certainly going to develop osteoporosis. So for these women, we tend to recommend hormone therapy. And then at 50, can reassess, you know, depending on their personal history, family history, personal values and desires, whether or not they continue hormones at that point. Progestogen, I mentioned, only if patient has a uterus. Otherwise, you don't need to give it, okay? And that WHI data comparing, you know, the estrogen progesterone group to the estrogen-only group is kind of provocative. And you might look at that and think, oh, well, it must be the progestogen that's the bad guy. Well, it turns out you can't really make that conclusion because those two groups of patients or subjects were sufficiently different in other ways that you can't make that conclusion. However, there is some animal data to suggest that synthetic progestogens specifically are bad for the breast, okay? So if somebody doesn't have a uterus, they should not be on a progestogen. If they do have a uterus, they need a progestogen, you have a few options you can use. Oral progesterones, there's patch available, like a combination patch. Progestin IUD is a very common form these days, just because you don't get systemic levels of the progestin, so people that are worried about breast cancer may opt for that. But the progestins have synthetic progesterone, progestogens, and I tend to prefer micronized progesterone, which is only available right now in an oral formulation. Prometrium is the brand name. All right, bioidentical hormones. I kind of told you what I use, estradiol and progesterone. Compounded stuff, I just don't think it's been proven. If a patient really wants to use it, of course, I'll keep them on and just monitor them for side effects and efficacy. A lot of naturopaths in the community check salivary hormone levels. I don't know if you've come across this. Not useful. There's no correlation between salivary levels and blood serum levels, so I do not find them helpful. How long you should keep them on kind of depends on what you're treating, right? If it's just the hot flushes, they tend to go away in a few years. So you could experiment, stop it after a few years. They might get some hot flushes when they stop, but typically they're not as severe as they were when first entering perimenopause. You don't need to stop. You can taper if you want, but you don't need to. You can also stop cold turkey. That's fine. If you have someone on for the prevention of osteoporosis or some other sort of long-term thing, then you might keep them on longer. And I certainly have patients that are, well into their 80s, still on hormone therapy. As long as they don't have, a contraindication, I will keep them on. Okay. In WHI, anyway, when they stopped the hormones, they still saw an increased risk in breast cancer in the group that was on hormones. But most of the other things were kind of a wash. There was no change or no difference in overall mortality in the hormone group versus the placebo group. Okay. So I guess the bottom line, it needs to be individualized based on patient's symptoms, their personal medical history, and their family history. Which I think is what this says. Just briefly, I want to talk a little bit about the non-hormonal options, okay? So if you have somebody who can't take estrogen or is concerned about the systemic side effects, I mentioned earlier, for hot flushes anyway, SSRIs and SNRIs are moderately effective for treatment of hot flushes. The other things on this list, I don't have that much more experience with. Gabapentin has also been shown to be helpful. I don't like it very much because I think I don't like the side effects, so I don't use it very much. I tend to use the SNRIs or SSRIs in someone who doesn't want to use estrogen. These are the ones that have been studied. All of these have been shown to be at least moderately effective. This is one study here on gabapentin, the crossover study showing decrease in hot flushes in the treatment group compared to placebo. And remember, when you're evaluating these studies on hot flushes, they have to be placebo-controlled. Because you can see, even in the placebo group, you see improvement. So unless you have a placebo-controlled study, you can't say that this treatment is effective any more so than placebo. So very important. Another venlafaxine has also been shown. And interestingly, the doses that you need to treat the hot flushes tend to be lower than the doses that you need to treat depression. So that's another advantage. Okay, this is citalopram in sleep is shown to be helpful. There's a lot of alternative therapies that have been studied, and a lot of this interest comes from looking at Eastern cultures where symptoms of menopause tend to be, for whatever reason, not as prevalent, whether that's cultural or true. People have looked at, so, what's the difference between Western lifestyle and Eastern lifestyle, for example, or diets, to look for clues for this. And of course, those people from Eastern cultures who move to the Western world then, develop increased incidence of all Western world diseases like breast cancer, heart disease, et cetera, presumably because something in their environment changes, whether that's diet or lifestyle. But to be honest, most of the studies that have looked at this have been pretty mixed and non-conclusive. Most of the studies are short duration, not necessarily placebo-controlled, have small numbers. So, we don't know. Plus, these things can't be patented because they're naturally occurrent, so there's no incentive really to study them. Supplement companies are doing just fine. Of the ones on this list, if I was going to use one, probably black cohosh has the most data behind it, and maybe acupuncture. But again, the studies are a little mixed. And as far as things like soy and phytoestrogens, it's probably really different to grow up in a culture where you're eating high levels of phytoestrogens from whole foods in your diet your entire life, compared to, you turn 50 and you start popping a soy supplement. That's like very different to me. So it's not surprising to me that most of these studies have been negative. Okay, so I do think there's probably something to, Eastern diet and Eastern culture, but it's not going to be replicated by taking a supplement all of a sudden when you turn 50. All right, so as I said, making the diagnosis, usually you can do by history. You don't need levels. Very rarely, if somebody's had a hysterectomy, so you can't really use their periods, for example, to determine if they're postmenopausal, I might get an FSH level in that scenario if there's any question about the diagnosis. But typically, the hormone levels are not useful. Screening, health maintenance, I kind of went through. I mentioned lifestyle factors, super important. Diet, exercise, and I know you guys know all this. Remember ethnic differences. And, again, bottom line is that decisions about hormone therapy need to be individualized based on patient's symptoms, their desires, their family history, their risk factors, and evaluated every year because, of course, those things can change. So hopefully that was helpful. I am happy to answer questions if there are any. Thank you. Yes?
Are there any special considerations for women who've had like a total abdominal hysterectomy at a young age?
So the question has to do with women who've had a total abdominal hysterectomy at a young age with intact ovaries, leaving the ovaries in.
Let's say ovaries removed.
So when those women are what I would consider premature menopause, I would tend to treat with estrogen only and reevaluate at 50 whether they want to continue or not. But I think for that patient, the benefits are going to outweigh the risks. They're almost certainly going to be symptomatic from not having ovaries, and they could develop osteoporosis, especially if they're young. And we used to be concerned, for example, if somebody had endometriosis, that's a common scenario where they would have hysterectomy and both their ovaries removed, that if you gave hormones, you would reactivate their endometriosis. We don't worry about that anymore. So even if you did the hysterectomy and bilateral salpingo-oophorectomy for endometriosis, you can safely give estrogen therapy.
And if ovaries are retained, anything specific for that?
So then I would just monitor them clinically until they went through spontaneous menopause and then use the same criteria. If they decided to go on hormones, then they would only need estrogen therapy and not a progestogen, even if they had endometriosis. Okay. Yes?
Thyroid showed up on a couple of your slides, and I confess I never would have thought of it. Is it hypo, hyper, and it makes the hot flashes worse? Is that the...
So not as associated with hot flushes as irregular bleeding. And both hypo and hyper can cause irregular bleeding. Hypo is more common. So it's recommended as part of the screening, anybody over age 50 have a TSH level every few years. And certainly anybody who has abnormal bleeding, we tend to get it. Yeah.
Thanks for a great talk. I'm just wondering, do you have any other additional things for women that have been through adverse trauma, such as women who are coming from countries where they're refugees, et cetera? You didn't mention domestic violence screening in general, but are there other considerations besides the screening in terms of mental status and
Yeah, thank you for bringing that up. Definitely an important topic. Domestic violence should be part of any encounter with a patient. Screen for that. I guess it comes up most often, in the sexual dysfunction. That's where we tend to have a lot of, positive screens for either history of sexual trauma or domestic violence. As far as hormonal considerations, I mean, you kind of sort of have to, do a multidisciplinary assessment of the situation. But sometimes there's coercion with a partner. We see this more with birth control pills and partners trying to control their partner's access to birth control pill. Haven't seen it so much with hormone therapy. I do think there are cultural differences in acceptance of hormone therapy as well. I think in some cultures it's just less accepted, and I may never see those patients for asking specifically for hormone therapy. But good point. I do think it's important to screen for that. Yes?
Will this age that a woman can safely, reasonably have a baby, and in exceptional circumstances, at what age could they consider having a child?
So the question has to do with advanced maternal age and pregnancy. So with ART, of course, IVF, et cetera, now women can have children even post-menopause. So the guidelines currently say the upper age limit is 55. And that's only because we have data up to that age group that it's reasonably safe. Definitely the incidence of things like hypertension, diabetes, need for C-section, obstetrical complications all increase as women get older. After 55, we just don't have a lot of data. There are not a lot of women in that age group coming to become pregnant, so we don't tend to recommend it. So most of us have at least a soft cutoff of 55.
My son's fiance is 45. 2 doctors or 3 doctors in the Bay Area have told her absolutely not. Is that because of malpractice?
Oh, yeah, no, we tend to be, I don't know if it's a different, culture, but we tend to be, value reproductive autonomy quite a bit. So we tell the patient, these are your risks, and it's up to you. So 45, I see lots of patients, 45 and older, that come for pregnancy. Often they have to use donor eggs, but, it's reasonable to also counsel them about the option of a surrogate. If they're concerned about the increased risks, then they can use a gestational surrogate to carry their child. But 45 seems like low to me. The risks are definitely higher compared to somebody who's younger, but we have lots of data in women older than 45, up to 55, as I said, that it's reasonably safe. Barring any other comorbidities. I mean, there's some like 30-year-olds that are sicker than my 45-year-olds. You have a 30-year-old who's morbidly obese with diabetes, hypertension. That person's a much greater risk in pregnancy than somebody who's 45 and, perfectly healthy.
Do you monitor them any differently when they're 45 or 50?
Yes. They might. I don't do obstetrics anymore, but I know the maternal fetal medicine people will monitor them much more closely because their risk of complications is higher. Yeah. So, which just means, more frequent visits and more frequent antenatal testing. Yes?
You mentioned routine annual pelvic exams. What's the evidence for that?
0. Yeah, no, it's 0. It's still recommended by ACOG, which is American College of Obstetricians and Gynecologists. That's why we do it. But if you actually look for data to support that recommendation, 0.
Why would you use something that has no evidence?
Because absence of evidence is not evidence of absence. It doesn't mean that it is. That's true. Yeah. Yeah, that's true. I think most people do it because of liability reasons. If somebody develops an ovarian cancer and you haven't done a pelvic exam and the guidelines say that you should be doing pelvic exams, then it's really hard to defend in court. But I agree it's not based on evidence. But I do also agree that it hasn't been proven to not be helpful. So even that encounter, having the patient come...
Things that have not been proven.
I agree with you.
That's how naturopaths.
Okay, I don't think we're going to resolve this, but I think every opportunity to have an encounter with a patient actually is valuable. So even if that's what brings them to the office, who knows? I might pick up something else at that visit. So, yeah. But if the patient says, you know what, I'm familiar with the literature, this is not helpful, I don't want to have a pelvic exam, totally fine with that. Just document it, declined. Good point. Yes.
On the same issue, has screening with abdominal ultrasound been compared to annual or whatever pelvic exam as a better screen for
Yeah.
cancers?
Yeah. Unfortunately, not cost effective. We do recommend it in BRCA-positive patients, but even there, it hasn't been shown to reduce mortality from ovarian cancer.
Even the portable ones? I know the portable ones are coming in.
Yeah, when it's much more expensive to do an ultrasound on everybody every year. And BRCA patients, we're doing them every 6 months. But even in those patients who are at extremely high risk, has not been shown to be helpful. Okay, thanks. Thank you.